want to get into now this discussion of the challenges and barriers of taking care of patients with diabetes. And so, if I could ask, everybody on the panel practices. Give me your best example of a patient where the chief complaint was diabetes management and you ended up finding yourself in a circumstance where it was absolutely essential for you to treat a comorbid condition in order for the diabetes to be treated. Can we start with you, Dhiren?
Sure. I think I'm going to piggyback off of what you were just saying. I think the biggest one that I see at my institution is depression. And so we have done our own projects and pilots, and we've looked at if the depression is poorly controlled, and just because of the patient population that I work with, the level of PTSD is really high, and same thing goes for depression. And so we work closely with those colleagues because it doesn't matter. I could prescribe the best drug out there that has low hypoglycemia rates and no weight gain and cardiovascular data and this data, but at the end of the day, if I don't solve that underlying problem, and it might be housing, it might be something else, or financial resources, it's not going to be effective. And so I would say, I think our patient population that have the underlying depression, we probably try to take care of that first before we even try to pitch any type of care plan or any advice that we might have.
So it's almost like a rule-out scenario for you where you say, I need to rule this out because I know this is going to influence the diabetes, and I know if I end up having to rule it in, that now I've got a scenario where I've got to approach this scenario differently.
Very much so.
And practice experience you've
had.
Yeah,
so this one is a tough one. So the resident came in and said, Dr. Peskin, we're doing fine with this person. The hemoglobin A1C is 7.2, below 8. The blood pressure is 128/73. The person was known to have high blood pressure. So listen to this, voicing no complaints today. I go into the room. There's a man there with a below-the-knee amputation, with a cane because he's essentially blind, and is about to need to go on dialysis. I said, after we left the room, because I didn't want to embarrass the resident, I said, we have failed this person. This person is now not our patient. This is Carlos's patient. Carlos, retired head of social services. So it just left an indelible impression on me. The consequences, the profound negative consequences of diabetes and its comorbidities. So it was really social services that all that we had to meaningfully offer that patient, because all of our interventions to control the disease had been inadequate.
So another example of if the focus is strictly on the pathology and nothing in and around the pathology, it's very difficult to change the health trajectory because of the pathology itself.
That's why I always tell residents, treat the patient, not the numbers.
Mm-hmm. Yeah. Practice experience.
There are a number, but the biggest side effect of a lot of the medications we use now is poverty. I mean, it's people not being able to afford medications is extraordinary, and they're embarrassed to say that. So patients who go without, patients who get their medications, but they're depending on food pantries for half of the month. So they only get rice. I've worked with a lot of immigrant families. I did a talk for a refugee clinic on diabetes, and I realized that I could tell how long each of the people had been here by their shape. They looked like typical people from Southeast Asia when they got here. They gradually got a big belly and skinny legs the longer they've been here, because they're eating so much rice, because the cheap food is what they can afford. And they feel happy to have it. They don't complain about their diet. They don't complain about access to food because they're full of rice. What they're saying good and bad is different than what we would expect. But helping them understand choices in food and making opportunities to do that is important. We've had patients who were marginally homed. They are not homeless exactly, but they weren't secure in their housing. Right. And insulin is not really a good option for those people. So we've had to use more oral medications, even in type 1 diabetics, to manage hyperglycemia because of their circumstances. And just knowing the whole patient is the key.
And what's interesting now is that there's a circumstance perhaps where the proportion of patients that are affected by inability or financial stressors from access to meds grows and grows and grows. You have middle class, middle income households that struggle to
The coverage gap in
obtain
Part
that.
D, we see it in the summer.
High deductible plans.
Right, we see it in the summer. Here it's folks doing really well, and then everything's starting to spike. What's going on? Well, they hit the donut hole in their Part D coverage. They're in a fixed income, and they were used to predictable payment for that prescription, and then all of a sudden it goes up. So that's a deal. And I'm going to go back to your question originally. I'm going to piggyback on this because we have hosted a free diabetes support group just as a community. We started teaching clinical diabetes classes and realized that's not what we needed to be doing. There's plenty of that out there. A lot of it is people go home to this environment that is not very diabetes friendly with respect to holiday meals and all these things. And so it helps so much to have people in a room sharing ideas and what dishes that they've taken to holiday events so they would have something to eat. And so those are the things that I think, when I can't think of a specific patient. I think of pools and panels of patients that we talk to in these support groups where really the benefit that they're getting out of this has nothing to do with clinical. It's just sharing ideas and learning how to live in their household and in their community and in their family with diabetes.
So
If I could mention,
Yeah,
so something he said was very important. It was the pharmacist's role in the donut hole issue. That if they let us know, if they say that this patient is approaching this, can we do this? This would spare them the cost until the donut hole. This product has a plan that will pay their medications during the donut hole. That kind of feedback that they realize the patient is getting into trouble or about to get into a problem that we may not.
So to me, that's a great example of an ongoing, living, breathing, dynamic care plan process.
Oh, yeah.
That's what you're describing. And the care plan is much more than just, you have diabetes of this type, and here's what the prescribed treatment is. It's all of those out in the world sorts of environmental considerations that go with it, and it's not a fixed thing in time. You're talking about a moment in time where things might change, and part of the care plan might be, hey, we need to check in midsummer with this patient and see if there's some affordability issues going on.
Yeah, Tripp mentioned holiday meals, and Richard mentioned food insecurity or a diet that's low cost. So I will kind of take those together and say that nutrition is an area where we're not doing a great job, and where there's ample information to show that we can significantly change the trajectory of diabetes with good nutritional support. And again, it is complicated and nuanced when you're talking about people being unable to afford fresh food, or there are these so-called food deserts. That said, is certainly an area where we have a very profound potential impact that's around nutrition.